Welcome to the podcast of the European Society of Anesthesiologists and Intensive Care. I am Professor Francesca Rubulotta. I come from the Azienda Policlinica Universitaria Gaspare Rodolico of Catania. And today we will try to dive into the matter of gender-specific outcomes in anesthesia. To explore this topic, I'm very honored to have with me Professor Daniela Filipescu from the Emergency Institute of Cardiovascular Disease of Bucharest. Welcome, Professor Filipescu.
Hello, Francesca, and thank you for the introduction. I'm looking forward for our discussion because this is a vital topic for improving patient safety.
Thank you for being here. And so let's start saying, why do biological sex difference affect anesthesia? Why should anesthesiologists worry about these matters?
So I think this is a vital topic, as I mentioned, for improving patient safety in the perioperative care and also for equity. And I'm convinced that we should discuss all the time about both sex and gender differences. Sex refers mainly to biological and hormonal, environment, and gender refers to social roles and behaviors of individuals, and both sex and gender shape how patients respond to anesthetics, how they experience pain, and also how they recover postoperatively. And historically, it's important to know that male were favored. In fact, only 3% of perioperative anesthesia trial and research looked to differences in outcome between sex and genders. And so we have to catch up to personalize care in anesthesiology practice.
Wow, that's a wake-up call on the importance of gender medicine. So let's start with some Q&A to unpack a little bit more this topic. So first question, how do the biological sex difference affect anesthesia and the management?
Well, sex impacts anatomy and physiology in ways that directly influence anesthesia. For example, women have lower cardiac mass, lower blood pressure, and higher resting heart rates, which can alter hemodynamics during induction. On the other hand, men have larger airways, which is good for the intubation, but female are more susceptible to hypoxemia during induction. Also, hemostasis is different, is sex-related, with women having a more hypercoagulable milieu compared with males. They have an increased platelet aggregation, and also the clot dynamics is more stronger, so they are exposed more to thromboembolism in the postoperative period.
Fascinating. So, Daniela, do men and women respond differently to general anesthesia?
Yes, absolutely. Because, it was shown that women show greater sensitivity to mu opioid agonists like morphine. In fact, it was shown that they require almost 30% lower doses for equivalent pain relief. Also, the neuromuscular blocking agents are different effects on male and female patients. Women have 30% increased sensitivity and have a prolonged effect for example, atracurium and rocuronium. And conversely, women need higher dosages of propofol for loss of consciousness, as they have lower plasma propofol concentration compared to males, despite the same infusion regimen. And this can be explained by pharmacokinetic parameters, but also sex hormonal variation.
Wow. Give me some examples. How do hormonal fluctuation affect dosing in women?
So um, it it is known that estrogen and progesterone have central nervous system effects. So the climate, the hormonal climate during the menstrual cycle has importance in determining the requirement of anesthetics. And for example, during the follicular phase, there is an increased need of anesthetics, volatile anesthetics and propofol, probably through GABA receptors modulations, MMDA receptor mediation, and also decrease inhibition of endogenous sleep by estrogen. And so because of this interplay between pharmacokinetic, pharmacodynamic pathways, I would affirm that usually, or let's say frequently, females are underdosed in anesthesia. And measuring with the current monitors, it's not always the solution, the best solution, because they are not so sensitive and specific. But anyway, we should use them.
Thank you. Are other sex-related issues that are important to quote, talking about perioperative care and management?
Yes, for sure there are lifestyle differences which can influence. They are very important in the perioperative care, and we know then that men have higher rates of smoking and alcohol consumption, and this can increase the risk of perioperative, postoperative liver and respiratory complications. On the other side, women have delayed diagnosis of diseases such as COPD, heart diseases due to atypical symptoms, and this complicates anesthesia planning because underdiagnosed morbidities may increase perioperative mortality. And it was a very interesting study I would like to mention, showing, the visual study looking to the association between myocardial injury after non-cardiac surgery and 30-day mortality. It was shown in this study, but reanalyzing the data, it was shown that self-reported history of preeclampsia in women having myocardial injury after non-cardiac surgery, means, the acronym. So these women had a higher risk of myocardial injury after surgery. So this points to the fact that we should have preoperative sex-specific evaluation tools.
Wow. That's incredible. And you have been a champion about the correct use of blood product. Are there sex-related differences that we should be aware of?
Oh, yes, this is a very important topic for me, and I would like to stress that I consider, and also there is a huge literature on this, that the traditional definition, the WHO definition of anemia is obsolete. And at least in the perioperative period, we should consider the same level of hemoglobin for defining anemia, 13 grams per deciliter for men and women individuals, and trigger, management in the preoperative period.
Yes, that's really important, and that's really relevant. And another curiosity, another questions. That's this discussion about differences in the preparation, differences in the use of blood. It's a game changer for preoperative and perioperative assessment. Are there any real world example that you wish to share with us?
Oh, the first real world example is from my institution, and we performed 2 studies, including in Bucharest in our institution of cardiovascular diseases, and we included more than 1,000 patients in cardiac surgery with cardiopulmonary bypass, and we showed that female sex is independently associated with perioperative red blood transfusion. And I will also mention a very recent study from European Journal of Anesthesiology coming from Netherlands, from a registry in Netherlands, including more than 7,000 patients with KBG surgery. And it was shown that 1 in 4 female patients had borderline anemia, so between 12 and 13 grams per deciliter. And this was associated with not only perioperative red blood transfusion, but with renal postoperative renal failure. So that's why it's important to treat equally male and female patients.
Yeah, so how do gender-related differences affect the perioperative management of patients?
Well, it was shown that the gender-related characteristic impacts cardiovascular outcome because gender determines access to healthcare, help seeking behaviors, and individual use of healthcare systems, including preventive measures and therapeutic, invasive therapeutic strategies. Moreover, gender norms shape how patients report symptoms, but also how physicians respond to this. And it is shown that women often report higher levels of pain sensitivity, partly through hormonal fluctuations, but there are also societal society expectations towards pain, and this can lead to biases. And in a study, it was shown that women receive less opioid postoperative analgesia because their pain was perceived as exaggerated. Meanwhile, male patients underreport pain due to stoicism, and this can also delay intervention, and it's not good as well.
So I said this is a crucial statement. Bias are big issues. Are there additional gender-related biases that we should address?
Yes, and this is very important question. Thank you for this. Gender, because gender influences how health providers, how us, we are taking decisions. So there is an implicit bias which may explain, for example, why women heart disease symptoms are dismissed by physicians and considered sometimes psychosomatic. And this can explain how female patients have higher rates of mortality after myocardial infarction, less evidence-based treatment for myocardial infarction, and substandard pharmacological treatment in these cases. And this have important consequences for the perioperative period because we have to optimize more, if I may say, our female patients with cardiovascular diseases.
How do sex and gender-related differences impact post-anesthesia outcomes?
Well, women recover after general anesthesia faster than men, even though the BIS level are equivalent. This is because pharmacokinetic and pharmacodynamic variables. However, these differences did not relate to faster discharge from ambulatory surgery. In fact, in a meta-analysis, including I think 44 studies, female sex was associated with faster emergence from anesthesia. They had faster time opening and response to command, at most 2-3 minutes less. But also, it was shown that they had greater incidence of awareness, which for me is failure of anesthesia. And we have probably to think if we have to reprise anesthesia care, and we have to think if this similar dosing for female and male patients is our best care. Also, women have 3 times risk of postoperative nausea and vomiting, which is very distressing. And this incidence seems to be higher in the follicular phase. So scheduling operations in the luteal phase of the menstrual cycle could help those with a history or strong history of postoperative nausea and vomiting, especially in ambulatory surgery.
Thank you. So, how do sex and gender impact postoperative outcomes?
Well, women are considered at a greater risk of postoperative complications. And I say considered because this is controversial. They also report lower satisfaction and lower health quality of life. But studies are variables, and some showed more complications, for example, in orthopedic surgery, because we have more studies in orthopedic surgery, and they show that female patients might have more transfusion and more infections, urinary infections, but male patients had more readmission to operating room, more wound infections, and even higher mortality. Interestingly, in a high database in South Korea, including more than 30,000 patients, the incidence of myocardial injury after non-cardiac surgery was lower in women, so they had a more favorable outcome after operation. Also, in spine surgery, it was shown that they experience less deaths, female patients. So probably it depends also on the kind of surgery, not only and age and other factors.
That's a good point and a lot of information. So, how all those mentioned differences impact specific procedures? For instance, you work in a cardiac center in Bucharest. So, how all those differences impact cardiac surgery, for instance?
Well, in cardiac surgery, female sex and gender was considered as an independent factor, risk factor for cardiac surgery, and included in risk costs like Euroscore. And this was also confirmed in the recent study where they looked to days alive or and away from hospital after surgery at 30 days. And women had lower values of this new parameter across all surgical groups. But in contrast, recently a propensity study looking to operations for thoracic aortic dissection, which are performed usually as emergent or very urgent surgeries, they found no differences in early outcomes after surgery, probably related to the marked improvements in surgical techniques. But still, the late outcome was better for male patients. Also, recently, total arterial revascularization proved to be equally advantageous for both sexes. Up to now, it was more indicated to male patients. And in transcatheter aortic valve replacement, there is an increased risk for intra and postoperative complications for female patients, especially especially bleeding complications or vascular complications, but the mid and long-term mortality is better for women. So this brings us to idea to recommend this type of surgery over open valve replacement at the lowest threshold for women.
Thank you. The beauty of anesthesia is that we work as a team and the team composition is relevant. May I ask you, what role do individual specialist characteristics, such as genders and sex, play in the patient's outcome? So how does the team reflect into the overall outcome for our patients?
So there are 2 points, one related to the individual and one to the team. I refer first to the individual because there is a growing literature demonstrating that sex contributes to differences in patients' outcome, with better outcomes among female physicians. And the large database, including both surgical and medical specialties, showed that mortality was significantly lower among patients of female versus male physicians. And also those treated by female physicians had the lower hospital readmission rate. Physician-patient sex concordance was also important and associated with better outcomes, especially among female patients. If they are treated so by a female physician, is better. And in a large population database coming from cardiac surgery, there was a small but significant association between anesthesiologist sex and patient outcome, with lower 30-day adverse outcome for those treated by female providers. Now, if we are going to the team composition, which we know that is recognized not only for equity, but also as a promoter for improved performance, this is very important to discuss, because usually in the operating room we are not acting as individuals but as a team. And a very nice study coming from US, including 88 hospitals in Ontario, found that gender diverse teams reduced perioperative complications. So if the care was performed in hospital reaching a critical mass of 30% of surgeons and anesthesiologists, so these hospitals had a 3% lower odds of 90-day major morbidity. And also in another study, again in cardiac surgery, all male intraoperative teams, so only male surgeon and anesthesiologist, was associated with a longer stay in hospital compared with all female team. And interestingly, sex discordant surgeon anesthesiologist teams did not adversely impact patient outcome after surgery. And I am living every day this. I think we have very good mixed teams in our hospital.
That's fantastic to hear, Daniela. Is any explanation that you can give of these results?
Yes, there are some explanations, especially there is difference in practice between male and female physicians. And probably there is a difference in communication style. Women spend more time with their patient to gather more information, and this can affect the perioperative care delivery. Women also tend to follow more clinical guidelines in practice, and the implementation of guidelines can improve quality of care. Also, women have a less risk behavior and and risk they exhibit less risky decision in their practice. They have also better communication and teamwork, and also different leadership style, which may be more conducive to optimal team behavior. And I think these differences are confirmed by a study looking to complications after central venous catheter insertion. And despite being less experienced, female operators had a lower rate of major mechanical complications. And probably this is related to the fact that they used more frequently ultrasound, which is recommended by guidelines, and also less risk behavior.
We are disciplined. Yeah. Let's speak about the future, Daniela, because it's beautiful what you do, the work you do. So, according to your experience, what role does gender diversity play in training future anesthesiologists?
This is very, very, very important, because there is unconscious bias. We cannot deny everybody is biased, but there is also a confidence gap between male and female trainers, and this impair learning, and in fact it's reinforcing the confidence gap, and this decrease the interest of mainly female colleagues in our specialty. So we should have a diverse team to have an inclusive training environment. It was shown that female educators and anesthesiologists rated more fairly the trainees, and in this way we can reduce bias in education.
Thank you. I have a strong believers of such, and I solely can add that I think we should be big mentors and sponsors of our junior generations. But you work in cardiac surgery. May I ask you, how can gender diversity in teams be practically really achieved in high pressure surgical environments?
This is, in fact, the key. We have to fight for formal mentorship, for programs for women, and also for sponsorship, which is more than mentorship. It's not only guidance. It's to be proactive in supporting, your trainees, your colleagues. I'm not supporting only my female colleagues, but I'm supporting my colleagues in the team in all ways, such as conference attending, for example. We should be allies, upstanding for our female residents to be retained in our specialty. And we these are not doing in our is not doing in our institution, but at the WFSA level, we started to develop targeted leadership courses and promote women leadership, because all this can amplify the benefits of balanced teams in anesthesia.
Wow, Daniela, this has been incredibly insightful. You've given us a lot to think about. What's one key takeaway message for our listener today?
Well, thank you for this. It was a pleasure to speak about this. I know that you are so passionate about this. I think for anesthesia that we should promote personalized anesthesia care based on sex and gender differences, to look to doses, to adapt to our individual patients, and also look to all monitors we have in the room, especially EEG monitoring for depths of anesthesia. And I would say that training of our trainees and our training is also important for team inclusiveness, because I like what you wrote in some, our colleagues from ESAIC wrote in some editorials. Diversity is a fact, inclusion is a choice.
Fantastic advice. Where can listeners learn more and read more about this?
Well, a couple of years ago, I wrote together with one of my male colleagues an article about sex and gender differences in anesthesia. You can have it, but there are more recent articles in the European Journal of Anesthesiology, British Journal of Anesthesia, Intensive Care Medicine, and for sure the book you wrote together with Vojka Neskovic, which is wonderful. I saw only, the some ideas about this. I would like to have it, but from the content, it's amazing.
You made me blush now. Thank you so much, Daniela. It has been fantastic. And thank you to everyone for listening to this episode. The ESAIC releases monthly podcast on the ESAIC website and various streaming platforms. We hope you will join us for the next one. And in the meantime, check the ESAIC Academy to listen to more enlightening talks. And I wish to thank you, Daniela, to thank you everyone for your attention, and I wish you a fantastic summer.